Ladies and gentlemen, distinguished guests, I thank Health Asia, I thank Professor Mohammed Azimuddin for having me here, and Dr. Raina Kalimi for all the hard work you guys have put in. It's a privilege to be here amongst the giants of radiology here, so it's a real honor. I think one of the topics that I was asked about was to talk about urological emergencies, and so there are differences between conventional urological emergencies and those that are emerging. So we'll start. Okay, so I have no disclosures. So we're going to talk a little bit about IR and urological emergencies. We're going to discuss well-documented acute cases, both new and those that are emergent, and have some interesting cases, and then to have some take-home messages. So why is IR important in urological emergencies? Well, it's rapidly available, minimally invasive, organ sparing, and often is the first line indication where surgery is not indicated. And there's usually a multidisciplinary approach with IR, urology, and usually with the intensive care unit. So what sort of acute conditions are we going to be talking about? Well, commonly we talk about urological emergencies that are both related to hematuria and trauma. And then I'm going to just touch upon some of the uncommon conditions like fistula formations, complications related to PCNLs, a high flow priapism, which we've seen a few cases of, and lymphatic leaks. So what are the well-documented common conditions? Well, these are acute hemorrhages that we've all dealt with as interventional radiologists. Trauma from penetrating or blunt injuries resulting in vascular injury causing perinephric hematoma. Iatrogenic injuries are often related to post-biopsy patients and PCNLs. So for interventional radiology, if you're doing a native renal biopsy, you tend to do one biopsy, but if you were to do any more than one biopsy, you increase your risk of having a bleed. Spontaneous hemorrhagic events tend to occur from things like acute myeloid leukemia, angiomyolipomas, renal tumors. So what's our role? Our role is one of embolization, selective and super selective. So what do we use in embolization? Well, we can use anything from gel foam, which is something that's commonly used. We can use PVA particles, which give you a wider surface area of embolization. We use glue now more and more commonly, and then often the main use of embolization materials is coils for selective embolization. So if you look at urological trauma, one of the things that we go by is obviously the American grading system, and anything that causes a penetration or a laceration of the kidney may require intervention depending upon whether the patient's hemodynamically stable or not. One of the things that can also occur is an iatrogenic injury is ureteric trauma. Now, one of the causes of ureteric trauma is post-surgical, whether this is related to gynae intervention or whether it's related to a laceration injury from trauma. One of the things that this is a take-home slide. What are the negative outcomes for ureteric injury? Well, the negative outcomes are if anybody has an injury that's more than 19 days old, then stent placement is going to be difficult. There's a poor prognosis where there's an avulsion, malignancy, and radiotherapy, and where you develop fistulation with the vagina. Urethral avulsion is almost impossible to treat from an endovascular, from a urological intervention. Now, we were going to talk about emergent conditions in this talk, so I'm going to be talking about other things apart from acute trauma that we may have to deal with. So, this is a condition that very, very few of us will see in our lifetimes, and this is a vascular urological fistula formation. These are the ureters on both sides. You can see this high attenuation material, which is a arterial blood flow inside the ureters. This is very rare, very few cases in the world, but the presentation results in catastrophic hematuria. And the gold standard investigation for this is angiography. You can do CT angiography, and various other investigations are also available. But the key thing here is for anything that's related to an arterial ureteric fistula formation, any delay in diagnosis results in death. So the risk factors for any of these formations, and I've seen one case in my lifestyle, I don't think many cases have, most of us won't come across many cases, but I had one case that I came across, and it was because of an indwelling stent that had been in situ for a long time. But the risk factors are here: pelvic malignancy, anything to do with pelvic irradiation, and pelvic surgery. So the fistula formation that I had in my case was related with where the ureter cuts across the just above the iliac bifurcation, and you can see that over time that it starts to merge with the vessel, especially if you've got something inside the ureter, and eventually that then creates a fistula formation because you see that ulcerative change here. This is the treatment options here, which is either endovascular versus open surgical. And the treatment modalities for endovascular are 4% versus 11% in terms of overall mortality. What are the new things that we can do for these patients? Well, you can have these aluminum nitinol stents, which is an intraureteric approach, and that reduces the rate of a fistula formation occurring. You can directly seal the ureteric defect, and again, from an emergency setting. Well, we're starting to see a lot more of these because of the emergence of erectile dysfunction medication. So, high-flow priapism is defined as persistent partial erection due to unregulated arterial flow. And usually, as you can see, you've got the structure of the penis with the corpora cavernosa, corpus spongiosum, and the arterial inflow here. The pathophysiology of priapism is that you get fistulation into the sinusoidal spaces, but the veins remain collapsed. And the commonest cause for this is usually trauma or pseudoaneurysm formation. And untreated can cause erectile dysfunction and necrosis. This is an arterial Doppler study, and you can show the arterial flow into the sinusoidal space of the corpora cavernosa. Then this is an angiograph, and this is where interventional radiology plays a role in its own, where you've got an arterial blush just here within the sinusoidal space, just here. Now, what are the treatment options for priapism that presents an A&E? Well, try ice cold compression, so conservative management. Where that doesn't succeed, with a spontaneous resolution of 60%, the other 40% may require intervention. And that intervention may require super-selective transarterial embolization, usually through the internal pudendal and the cavernosal artery. The treatment options are either temporary with gel foam or permanent. Now, this is a case that we did where we had a contralateral approach, femoral arterial intervention, and we identified the internal pudendal artery and then the cavernosal artery into the site of where there was an arterial blush. We had a Cobra catheter that was used for those who are interventional radiologists, and we used a microcatheter for super-selective catheterization. Following embolization, you can see that arterial blush has gone and the cavernosal artery is preserved. So the key thing for priapism is that you need to determine whether you've got a high or low flow priapism. You need to determine whether you're going to have first-line treatment, which is the management of the priapism itself, or whether you're going to have an endovascular approach. But super-selective approaches are important to avoid non-target embolization, as we have to avoid this. Another feature that is now becoming emergent in urological intervention is lymphatic leaks. And I'll give you an example. Prostate cancer surgery involves people having nodal resection. Any nodal resection then results in a lymphatic leak. And that can be either from renal transplantation, pelvic lymph node dissection, and usually anything to do with lymph nodes. What happens if that occurs? Well, you develop chylosocieties, lymphocyte formation, which can be localized or diffuse, or chyluria. So what do we do as interventional radiologists? Well, lymphangiography we can do, which is a diagnostic procedure, and the whole point here is to identify where the lymphatic leak's occurring. How many of you have done pedal cannulations? Not often, but the way you do it is to do either a pedal cannulation here or into the nodes, an intranodal lymphangiography. And the goal being that you seal the leak. These are the agents that we can use. And this is a lymphangiogram that opacifies, you can see the internal thoracic duct here. So the lymphatic anatomy you need to define, you need to know what you're dealing with, and it's very much an emerging, advanced form of imaging that is now becoming something that as interventional radiologists we may be required to do more and more often. And what you do is administer contrast into the lymph node, and you then start to develop a lymphangiogram, and then you realize where the issue is before you then start to treat it. The treatment options are either a hybrid embolic agent or MR-guided lymphatic embolization. Of course, now with the advent of AI, that is aiding lymphatic mapping for preoperative surgery. Another feature, because we're doing more and more stone surgery, is complicated PCL emergencies and dealing with the outcomes. Now, usually PCNLs are minimally invasive procedures that allow you to treat stones. Gold standard is for any stones larger than 2 centimeters, you do PCNLs. It's minimally invasive, but it's never complication-free. Complications can range from minor bleeding to sepsis and organ injury. Hemorrhage. How many of you have had to deal with hemorrhagic problems after PCNL? One case that sticks with me is a 41-year-old guy who we were doing a PCNL on, and the patient developed acute arterial bleed. Now, the reason why I say this is a case I had about early on in my career, and the patient had a hemorrhagic event that was so massive that the patient ended up dying on the table. Now, one of the things that we didn't know at the time was how to stop the hemorrhage. The urologist, we put a catheter in, a nephrostomy, but the urologist insisted on leaving it open. So there was no tamponade. Arterial blood was coming out. And as the arterial blood kept coming out, the blood pressure dropped and the patient died. The question is, at the time, what was the alternative? Instead of embolization, we didn't have time for embolization. Patient's blood pressure dropped. A life-saving technique is to put a Foley a Foley catheter into the collecting system, blow up the balloon, create tamponade, and stop the bleed. And with hindsight, I wish I'd realized that a few years earlier. But one of the things you can do, if you do have time, is to do a CT angiogram, you do super-selective embolization, and literally save the patient's life. Bleeding from a PCNL is fairly common. One of the other things that you do see, again from PCNLs, is sepsis. And IR management is obviously nephrostomy insertions. So what's important is that you need to rapidly assess the post-PCNL imaging, decide whether you're going to do super-selective embolization, attempt to do a percutaneous drainage with a nephrostomy, and decide whether you need to clamp the nephrostomy. And then obviously just do not do things on your own. Discuss with the critical care team. Now, a few notable cases that we're just going to go through. 58-year-old female with abdominal pain, virgin abdomen, hemoglobin of 80. So you can see here that there's a large perinephric hematoma. This lots of fat here, so this is an angiomyolipoma. Patient presented to the emergency department moribund with a hemoglobin of 3 grams. Clear, large arterial bleed. This required a straightforward embolization. So we did a super selective embolization. We used a combination of coils and PVA because there was a large surface area. So you can use the combination depending on the surface area of the angiomyolipoma. So do not just stop with just one or the other. Here we use multiple coils, and that's an example of using more coils to stop the bleed. Another patient was a 73-year-old, long-standing renal calculi for PCNL. Patient had these are the calculi that you can see. This is after this CT. You can see that the filling defects are because of the stone, direct puncture. And then after the procedure was done, the patient developed a significant bleed. And you can just see here, I don't know whether you can appreciate, but there's a arterial blush. If you then follow this through, the patient then had a persistent blush, which was not seen on the non-contrast CT, and that therefore is a pseudoaneurysm. You can see the pseudoaneurysm here. Identify the pathology. It's important to realize that you're either going to have an arterial laceration or you're going to have a pseudoaneurysm. Identify the pseudoaneurysm, and then we went on and proceeded to embolize that with the coils and got a great result. So in other words, there are newer pathologies that we're having to deal with in the emergency department. PCNL complications, lymphatic complications from prostatic surgery, and acute AMLs, and anything trauma-related as well. So IR has a central role to play in these emergencies, and I always say that always anticipate your pitfalls and make sure that you talk to your colleagues, because that can save patients' lives. Thank you very much.